Yeah, hi, I'm Neil Hannan. I do a lot of the more advanced surgery here at Southern Cross, and Dr. Sam has asked me to speak to you about cruciate disease and the range of techniques that can be used to surgically manage cruciate disease, and kind of give you an idea of the differences. So if we start with perhaps the simplest, and that is the lateral suture. It's frequently referred to as the annulus, although there are many variations. Basically, there's a piece of synthetic material, suture, which is put on the outside of the joint and restrains the shin bone, the tibia, from moving forward in relation to the femur, which happens once the cruciate is ruptured. So we're trying to stop that happening by using this suture, and that works pretty well in little patients, so less than 10 kilos, as long as there are several factors that are taken into account. It won't work if the top of the tibia is very highly sloped, and as the body weight increases, it won't work. So if you've got a very fat patient, even if it's 10 kilos, but it should be 5 kilos, then the lateral suture is going to not work as well, because where you place the lateral suture is not going to be particularly strong. The next group of techniques are what I would term the leveling procedures, and there's a lot of them. But the main ones that are used are Tibial Plateau Levelling Osteotomy, TPLA, Tibial Tuberosity Advancement, TTA, and Triple Tibial Osteotomy, or TTO. All of these techniques aim at changing the relationship of the top bone, the femur, and the bottom bone, the tibia, so that when the patient stands on that leg, the tibia doesn't pop forward in relation to the femur, and so the need for a cranial cruciate ligament is kind of overcome, if you like. Now, these things work, but they don't work perfectly, and they don't work perfectly because, one, we've got long-standing disease by the time the surgery is done, but also, more importantly, that the native cranial cruciate ligament does more, much more, than restrain the movement of the tibia forward in relation to the femur. There is a very strong component of a rotational component of the femur rolling outward and pointing outward in relation to where the tibia is pointing during weight bearing. This varies. If it's a whippet, there's hardly any. If there's a French bulldog, there is up to 35 degrees. So there's a lot of rotational change. These other techniques that I've described do little or nothing to overcome the rotational component. A number of new internal prosthetic materials have been released: Zed League, League, and in people there's a prosthetic called Lars. These have revolutionized the management of cranial cruciate disease, and you may be familiar with the Lars technique in that it is the one frequently used in athletes, where the aim is to get them back on the field quickly. So with the Zed League, which is one that I use, I still do TTOs, but with Zed League, the main valuable features of Zed League are that it overcomes the rotational forces as well as the craniocaudal forces, and so normalizes the joint movement. It also means that the patient doesn't have to be restrained. In fact, it's contraindicated for the patient to be restrained for a long time, and the post-operative rehabilitation is therefore less lengthy and much easier to do. So the patient has to be kept quiet inside the house, but taken on lots of controlled walks with sitting and standing, just while the soft tissues heal. And that also helps to send messages to heal the bone in around the implant, where the implant passes through the bone. So you get better bonding and better overall result. So all of the techniques work, and the leveling procedures have been the mainstay and will certainly continue to be used predominantly for a long time, I suspect. But the introduction of Zed League, which is now only 6 or 7 years old in Europe, which is where the origin of this technique was, and now only a couple of years in Australia, it's proving quite a good innovation, and we're getting a collection of patients with very happy owners as a result of its use. So that is a quick summary for you of the 3 major groupings for the management of cranial cruciate disease. And it was interesting, at university I used to say to my students, the cruciate disease is something where every surgery works and none of it works. And what I meant by that was all surgery will work when appropriately selected to have a pet patient return to a reasonably good function as a pet. It won't get a racing greyhound back on the track. And I think that still holds true, although we're getting closer with things like the intra-articular implant of Zed League.